Good day to all of you. A warm welcome to everybody attending. My name is Margot Kooijmans. I lead Philips Foundation and Philips Foundation Impact Investments. And Philips Foundation, as you meanwhile know, focuses on providing access to healthcare for the underserved. We do this with our partners, on the one hand through grants and donations, on the other hand through investments in interesting, innovative, small ventures. And we build upon what we learned during our work and along the way. And we want to open up our knowledge and our lessons learned through our knowledge base that we built. And one of the ways to share our knowledge and what we've learned is by this webinar series. In order to improve healthcare for the underserved, we need to work together. And this is what we try to do, among other instruments, through these webinars, to discuss, to learn, to share, and to collaborate. We can have a look at the world map in the slide, and still 4.5 billion people are deprived of essential healthcare services. This is something we will not accept, and we want to work with you, with our partners, to improve that. Of course, we are aware that most of the people deprived of healthcare services live in the global south, but this map, and especially the green areas, conceal that still in, for instance, Europe, there's still a lot to do. And that is what we want to focus on today. We are very grateful for the seasoned speakers we have in our panel today. And I hope you will learn, you will help us to rethink ways to provide access to healthcare for the underserved, even in Europe. And over to you, Victor, for closer introductions.
Thank you very much, Margot, and good day, everyone. Thank you so much for taking the time. We are super excited for you to join today's webinar. My name is Victor de Boer. I am a program manager for the Philips Foundation, overseeing our grant-based projects. And I'm really honored to moderate our 7th webinar in a series on strengthening access to quality healthcare for underserved communities. So today we will explore together the topic of access to cardiovascular care for underserved communities in Europe. The topic is of key importance to the Philips Foundation, and we have collaborated with partners around the world, as you just showed as on the slide, Margot, to explore innovative ways of improving access to care. And for good reason. Cardiovascular diseases are the leading cause of mortality in Europe. It covers a staggering 1/5 of premature deaths in the European Union alone. And while deaths caused by cardiovascular disease overall are on the decline in Europe because of improved healthcare and more awareness, the place where you were born to a large extent still determines outcomes. So compared to other parts of Europe, mortality is highest in Central Eastern Europe region, as you can see on the next slide. But underserved populations within European countries, such as refugees, ethnic minorities, people with low income, low education, low employment levels, tend to suffer disproportionately and really face worse disease outcomes. The European Alliance for Cardiovascular Health calls this Europe's biggest health challenge. So let that sink in. They note that for a collective European cardiovascular health plan to be successful, inequities and barriers to access must be addressed. So, in today's webinar, we want to explore and hopefully answer the question of what we can do to halt the rising burden of cardiovascular disease in Europe. To help shed light on this incredibly complex but extremely important question and guide us towards possible solutions, we have invited 4 top thought leaders with incredible track records in the field of cardiovascular health. So, in the first panel of today, we are honored to have with us Professor Fausto Pinto. Professor Pinto is a distinguished cardiologist and a professor of medicine. He's currently president of the Cardiovascular Center of the University of Lisbon. And before this, he founded the European Association of Echocardiography. He was president of the European Society of Cardiology, and last but not least, just last year ended his term as president of the World Heart Federation. So Professor Pinto will provide an overview of the huge burden of cardiovascular disease in Europe, further discuss the drivers of health inequities, and also priorities for action. So then we will move to the second panel discussion of today, where we will actually zoom into specific country learnings from Italy, Romania, and the United Kingdom. And we will do this together with Dr. Stefan Busnatu, Dr. Rajay Naren, and Dr. Valerio Mongini. So Dr. Busnatu is a cardiologist at the Bagdasar Arseni Emergency Clinical Hospital in Bucharest. He's also a lecturer and vice dean at the Faculty of Medicine of the Carol de Villa University of Medicine and Pharmacy in Bucharest. Dr. Narain is the founding director of Global Health Alliance in the UK. He's also an honorary consultant cardiologist at the St. George University Hospital in London. And lastly, Dr. Valerio Mongini. Dr. Mongini is the head of emergency health response for the Italian Red Cross and public health practitioner with a special focus on health response in emergency contexts and community-based projects. And then we will close today's webinar with an open dialogue where we invite all four panelists to share their thoughts on opportunities, lessons learned, best practices. And for this final panel, I would also like to encourage everyone currently on the call to submit your questions throughout the webinar, actually, in the chat, because we will have a chance to answer them during this closing session. Now, with that, I would like to move to the first panel and give the floor to Professor Fausto Pinto to learn more about the cardiovascular disease burden in Europe and priorities for action.
Thank you so much for the invitation to be here. It's a pleasure. And I'm delighted to speak also on behalf of the World Heart Federation and provide you a little bit of data and a little bit of food for thought for our discussion today on cardiovascular disease and inequalities in Europe, and I would say around the globe. If I can have the next slide. I will just give you a short introduction on what is the World Heart Federation. It's an umbrella organization that represents the global cardiovascular community with these three main goals or three main pillars. On one hand, to connect, lead, and inspire the cardiovascular community, to translate science into policy, to influence agencies and governments, and that's a little bit what we are trying to do with discussions such as the one that we are having today. And finally, to stimulate the exchange of information to achieve our goal, which is cardiovascular health for everyone. If I can have the next slide. And we do this through our members. We have more than 200 members around the globe, which includes not only scientific societies, but also foundations and patient groups, very important part of our community, because those are really the chains, the tools that can help us to reach out to the decision makers, which is essential to take decisions that can actually influence the communities and the populations. And we are in official relations with WHO, working very closely with the World Health Organization to advocate at the highest levels to bring cardiovascular disease to the forefront of the global health agenda for the very simple reason that cardiovascular disease, as was mentioned already, is the #1 cause of death globally at the global level. So if I can have the next slide. But to know and to convey these messages, we need to have data. Data is knowledge, data is power. And that's why we organized the World Heart Observatory, which is a one-stop platform for global data on cardiovascular disease. And we published this year, if I can have the next slide, the World Heart Report, which condenses a lot of information in terms of cardiovascular issues, data coming from the GBD group, from NCD Risk Factor, NCD Countdown, WHO Global Health Observatory, and we're working with many of our partners to provide that sort of data that can help us then to convey all this important information that then can be used to take the right decisions. Because we need to be aware, first of all, of the dimension of the problem, so then we can set the policies that can help us to overcome those issues and those problems. Next, please. So let me focus now on what is the main purpose of our discussion today. Well, first of all, the challenge is that we have over 100 million people living with cardiovascular disease in Europe, and this has actually been increasing over time. At the same time, there is some progress. There is a falling in age-standardized death rates in both sexes, so we have been actually good at treating cardiovascular disease. The problem is that we have not been so good at preventing cardiovascular disease because we have not been so good at tackling the main risk factors for cardiovascular disease, particularly knowing that 80%, 80, of cardiovascular disease is potentially preventable. Next. And that's why it's so important to address the issue of inequalities. You already saw that there are clear regional inequalities in Europe. We have the highest death rates in Eastern Europe, but even within the same countries, sometimes there are some differences and inequalities that have to be known so we can address these important issues. Next, please. And that is why we've been looking at these different risk factors and how much do they compare within Europe and also how do they compare in different parts of the world. On the top left, you can see the level of low physical activity in men and women. The more red means less activity, some differences across Europe, but in many countries still a big problem. Like high sodium intake, both in men and women, which is still an issue in many parts of the world. Raised blood pressure, hypertension, it's a big issue, which we're still facing at the global level and in Europe, of course, and particularly in Central and Eastern Europe, it represents a very important component of the risk factor, which is responsible for the high death rate that we are seeing and prevalence of disease that we are seeing, particularly in Eastern Europe. And finally, non-HDL cholesterol, which is also a big issue still, dyslipidemia in many parts of Europe with some inequalities. Next, please. Another important element has to do with the social determinants of health. These are the main drivers, in our opinion, of health inequities. There are key determinants here, which include age, sex, education, and socioeconomic position. General environmental conditions are determined by both national and international policies. And these inequities can be within and between countries. And this is certainly one of the main aspects that we have to face. And we have, again, to find solutions to overcome these social determinants of health, which have a major impact on the development of disease. Next, please. And this is clearly shown in this slide. On the left-hand side, these are figures taken from WHO Europe on health equity data set. On the left, it shows greater reported unmet healthcare needs in people with low and mid education in the Netherlands. And on the right, it shows greater age-standardized cardiovascular disease prevalence among low-educated and medium-educated than high-educated people in Portugal. So the level of education, now we know, it's also a risk factor for cardiovascular disease. Next. And this can, again, be shown here, which shows that significant reductions in age-standardized mortality have been observed across all education levels in Europe. However, reductions have been quicker in the highest educated groups, increasing relative inequalities. So a big issue that we have to face and we have to find ways to address and to overcome. Next, please. And here we can see that the cardiovascular health plan for Europe is something that we really need to implement. There is a health plan for cancer in Europe, fine, but we need one in Europe. And this is now being actually worked out at the European Parliament through some of the MPs that have been very much committed to this process. And there are priorities for action that have to be clearly stated. Guided by the burden of disease and predominant risk factors, the different countries should implement policies to combat cardiovascular disease, ensuring the implementation is adequately resourced and monitored for progress. So it's not only about doing the measures, implementing the measures, but monitoring how the progress is being done. Develop national cardiovascular disease plans, and we have a good example from Spain, including clear actions and targets for primary, secondary, and tertiary prevention of cardiovascular disease, and implement them with appropriate levels of investment. Ensure the measures to decrease inequalities that are reflected in national cardiovascular plans. And as I mentioned, the example of Spain that developed a national cardiovascular strategy that sets a good example, including commitments to monitor how progress on all strategy targets vary according to socioeconomic groups, a checklist to ensure equitable implementation of actions and specific actions to promote equitable care for women, which is also an important issue, cardiovascular disease in women, which for many years was not so well recognized. Next, please. And finally, I want just to leave a word here of some of the things we are doing at the World Heart Federation, particularly this big show, which is the World Heart Day that we've been organizing now for many years, 29th of September. The motto is beating cardiovascular disease together. The World Heart Day is a reminder to everyone around the world to take care of their hearts. And this year's campaign focuses on the essential step of knowing our hearts first. Because when we know more, we can take better care of ourselves. So our motto of use heart, know your heart is very relevant to increase the awareness of cardiovascular conditions, of cardiovascular issues around the globe. So again, the different governments, the different decision makers can actually take the right decisions to provide that sort of examples that can be used in the populations to reduce the burden of cardiovascular disease and provide cardiovascular health for everyone, which is our main goal at the World Heart Federation. And I will say that as a community, we have that responsibility to make sure that we find those ways to achieve this goal. And with this, I finish my presentation, and then I'll be delighted to discuss during the discussion time some of the issues that we're going to be discussing today. Thank you so much.
Thank you, Professor Pinto, for providing this comprehensive overview of challenges, main risk factors, regional inequalities, but also laying out these clear priorities for action. I think also the importance of data and monitoring of progress to tackle this burden is duly noted. So definitely food for thought, and we'll be sure to join, obviously, World Heart Day as well. So now with that, we will continue to our second panel of this webinar. And I would like to give the floor to Dr. Busnatu to share his unique insights on cardiovascular disease burden in Romania. So Dr. Busnatu, the floor is yours.
Hello, thank you very much, Victor, and thank you to Professor Pinto for showing us the Europe vision in terms of cardiovascular diseases. I represent basically the eastern side of Europe, and as you previously seen in the map that Professor Pinto showed to us, and I also attached a map related to the cardiovascular risk around Europe. The Eastern Europe, it's in the red zone in terms of cardiovascular diseases risk. And this is mostly due to the fact that we have a lot of challenges. And I'm going to speak a little bit about the challenges that we are facing in Romania and also in the closing countries. Challenges that put us at the level of 60% mortality each year in terms of cardiovascular diseases when comparing it to the other causes of death. So we have a very high prevalence. It's a big health problem. There is a limited awareness around this topic because we have a national plan of cancer, like Professor Pinto said. Everyone is speaking about cancer, and we all know that cancer is a really big burden for the society, but too little people speak about the cardiovascular diseases. On top of that, we have the healthcare infrastructure, which is old, which is from the communist period, and the infrastructure that has not been developed further and improved in terms of digitalization, which is very much needed in order to improve the medical services. Eastern countries have a big problem on shortage of healthcare professionals, especially doctors and especially nurses, which are leaving the country due to the low incomes that are provided inside Romania. On top of that, Professor Pinto spoke about prevention programs. Eastern European countries don't have secondary prevention programs. They don't have cardiac rehabilitation in order to put the population on track after a myocardial infarction, after an operation on the heart, or after a heart failure hospitalization. A part of that, the treatment of the cost, especially of the cost which are related to surgeries, are very high in the private practice, and there is a low accessibility for patients to get in the public sector to do these complex procedures when the time comes. And what is the most important, if we would like to take into consideration when speaking about public policies related to cardiovascular diseases, and also to do good research in the direction of prevention and mitigation of all this public burden, is that we don't have aggregated data to use it and to do the activities that I mentioned. The last thing, which probably it's not so important, but it's also a burden, is the access to medications, which in some situations is a little bit prohibitive due to the high costs of the new antibodies that need to be used for severe dyslipidemias, which are not so easy to be provided for our patients. Next. If we speak about solutions that could be implemented in order to improve things around here, I would say that the public health campaigns are very much needed in order to raise the awareness as it should be, and to make people notice that they need to do more prevention in order to avoid hospitals. We will need to have more funding for healthcare infrastructure and for ensuring workforce capacity. This will also allow basically increased access to preventive services and policies. And we need to fight more against smoking and obesity. We also need to figure out a solution to build a telemedicine system, because this could provide coverage for rural area and underserved areas, at the moment not being functional in Romania, although WHO says that 70% of Europe uses telemedicine. Romania is not part of the countries that use telemedicine. And also we need to digitalize the documents and be able to create medical registries. Next. In terms of the lessons that we have learned, basically, from other countries, because in this morning I listened to also to the Netherlands Ministry of Health and Welfare, and he was speaking about connection with other countries and learning from other countries and implementing solutions. We need to recognize basically that prevention has a critical role in reducing the burden of cardiovascular diseases and promote these actions like physical activity, better nutrition, and especially smoking cessation for reducing cardiovascular risks. Encouraging regular checkups and especially implementing digital solutions for doing regular checkups in order to ease the access for the services for the population. It's very important in order to ensure early detection of risk factors in cardiovascular conditions. There should be efforts made to reduce healthcare disparities between urban and rural areas, because I could say to you that in Bucharest we have a lot of cardiologists, for example, but in the 5 cities that are neighboring Bucharest, we don't have more than 5 cardiologists added for all the cities. So this is a very big problem when it comes to the coverage of the medical services in Romania. And in terms of plans, we need to build up this national plan of cardiovascular diseases. We started working, we are in the process of working on building a national plan for fighting cardiovascular and cerebrovascular diseases, and to implement obesity programs, especially among children and adolescents, that could also change in 10 years the face of the cardiovascular risk in Romania. Thank you very much.
Thank you very much, Dr. Basnatu, for providing these insights and also emphasizing the importance to speak out on the importance of cardiovascular disease, stressing the importance of secondary cardiac rehabilitation and getting more aggregated data, and listening to your lessons learned. Very insightful to learn about these disparities also between urban and rural areas in Romania and the availability of services. So let's now continue to Dr. Narain to learn about the specific situation in the United Kingdom.
Thank you so much, Victor, for the kind introduction, and thank you to Philips for inviting me to this very important meeting. I think this is one of the key areas that we all need to address globally as healthcare professionals, because this is one of the biggest challenges that we are going to face in the coming months and years. As you can see from my first slide, that on the top left, this is the global burden disease data, which talks about the top 20 causes of death. I'm just displaying the top 10 here. And you can see that ischemic heart disease and heart disease is number one globally at the moment. But in 20 years' time, heart disease will still remain the biggest cause of death at a global level. So what do we need to do? One of the important things that, again, we need to address is to try and address most of the risk factors that lead to ischemic heart disease. For example, diabetes is sitting at number 15 globally, but you can see in 10, 20 years' time, this will jump on to number 7. So we know that when people get diabetes, the chance of ischemic heart disease or coronary artery disease or heart attacks, they increase further. So that is why we need to be more aggressive in our approach in addressing some of these risk factors which lead to ischemic heart disease. And this has become more challenging post-pandemic. As you can see at the bottom of the slide, this is the Pulse survey, which was published by the WHO recently. And the Pulse survey said that almost 90% of the countries in the world have shown disruption to the essential health services. And in fact, 70% of the targets in non-communicable disease like heart disease, cancer, diabetes, kidney problems, which are the top 10 killers globally, almost 70% of those targets in 90% of those countries of the world that we are talking about are going to get affected. So we really need to step up our challenge and face this in a more aggressive way so that we can try and screen more people, pick up all those patients who are risk factors for coronary artery disease, for cardiovascular disease. Coming to UK specific, almost 7.6 million people suffer from cardiovascular disease in the UK. Almost 1/3, 27% of the deaths are from cardiovascular disease. Not only that, there is a big health disparity, because if you look at different parts of UK, there's almost about 18.6%, 18.6 years difference between the life expectancy if you live in one postcode compared to the other postcode. For example, the parts of South Wales, East Scotland, Northern Ireland, Northern England, these are some of the areas where health education, health delivery systems have not been able to work as effectively as compared to some parts of Birmingham or some parts in London. And this is again because of some of the psychosocial factors, some of the health habits like smoking, diet, lifestyle, exercise, not having that knowledge, because during the pandemic, there was not enough education that was being delivered at community level that lead to many of these problems that we are facing at the moment. But more wider determinants are also important, like employment, education, and their jobs, because again, we are in the process of, again, going through a very difficult phase post-pandemic and post-war in Europe, that many of those challenges are very difficult to meet, especially during the economic crisis that the UK is facing at the moment. And this is wide across, again, in male and female in both sexes. If you look at the life expectancy in males and females, almost 50% of those challenges, the life expectancies that we are talking about in cardiovascular disease and cancer, are because of heart disease and cancer. So again, we really need to step up and do more to address this challenge. Next slide, please. So again, what is the solution? The solution is that we need to have a re-strategization of what we need to do. So we need to reignite, we need to bring in community members, researchers together. We need to rethink these strategies, because only then we'll be able to have a sustainable model, work on some of those SDG models that will bring in all those factors that play in community an important role in addressing some of these health equities. Because unless there is a better partnership between the primary care, the secondary care, these challenges will remain always a challenge for the coming months and years. And this is why it is important, because this is all evidence-based. This is again on the right side of the slide, you can see these are the top 16 studies which were done to look at how to address cardiovascular disease more effectively. And some of the interventions included health education, health promotion, motivational counseling, and provision of learning materials on social media platforms. And out of those 16 important studies in addressing cardiovascular disease, 12 of these studies showed that health education was most effective as a strategy to address cardiovascular disease, because that led to better cardiovascular disease knowledge of the risk factors, and their risk profile went down because they learned about what are the risk factors from diabetes, from blood pressure, from the cholesterol side of things, from the diet and exercise side of things. So I think health education is something that we really need to focus on as a community, as healthcare professionals, to deliver better health education for the community. Next slide, please. So this is what we are doing in the UK. This is part of the NHS long-term plan by trying to integrate some of the goals across high impact changes that we are trying to achieve in the coming months and years, because we know cardiovascular disease will stay a big challenge for the UK as well as it is for all of Europe and globally. And this is what we are doing as part of the CPIP program, which is Cardiovascular Improvement Program, trying to address prevention in a better way. So trying to achieve some of those targets, which again have become quite challenging during the pandemic. So trying to pick up all those diagnoses at an early stage, trying to reduce the waiting list by having a better intervention, a better strategy and picking up some of those risk factors early in the community, and enhanced recovery, because that is how we are going to have a better experience of care, more equitable access and a sustainable cost, which again is very, very important for NHS, because in NHS at the moment we are having lots of issues when it comes to delivery of healthcare system, especially post-pandemic. Next slide. So what do we need to do? So the lessons learned are that we need to have a strategy where there is practice of self-care by all age groups for a healthy lifestyle. And this has to be achieved through a holistic approach, a holistic cardiovascular disease approach with specialized cardiology input, which is very, very important, because unless there is research to tell us what works, what doesn't work, like what we just discussed about the 16 different kind of researches. So I think cardiology input is very, very important, which should become the part of the society, part of the culture of the society. There has to be a tailored support for the deprived community. So again, picking up all those gaps which exist in some of those postcodes, which are referred to as unlucky postcodes in the UK. So we need to address what needs to be done there to improve some of those service delivery, to improve picking up those important diagnoses at an early stage and addressing them properly. But more importantly, supporting the NHS, because unless there is better primary and secondary care participation and partnership, we won't be able to support the NHS with regards to screening these people, picking up all those diagnoses early, which remains the mainstay of addressing cardiovascular disease at a national level. And obviously working with NGOs, working with foundations like Philips Foundation, which is doing fantastic work at a global level, which is very, very important that we work together, bring in all those partnerships, all those concepts together, and have a better awareness and understanding of the problems in delivering some of those solutions. Thank you very much.
Super interesting. And what was really striking also to me is to learn about the life expectancy gap of 80.6 years, I believe, between different populations in the UK, and also the importance of equitable access, health education, really the need for collaboration between primary and secondary care in a holistic manner. It's well noted. We will now go to Dr. Valerio Mogini to gain more insights into the situation in Italy. So Dr. Mogini, the floor is yours.
Well, first of all, thank you for having me and inviting me. I'm very happy to be the last one, basically, because most of the speakers before me have already highlighted a lot of interesting themes to discuss. What I want to focus at first, it is something that has popped up, but I feel this is very important, which is the access to healthcare. So this is a multidimensional problem and issue that sometimes is not considered as enough. I mean, we have been talking about social determinant of health, which obviously should lead the policies, should lead the way in which we shape our action. But the access to healthcare is made of many different pieces that needs to be taken together or by different organizations to ensure that everyone can actually can effectively access healthcare at the same time. Cultural, economical issues must be taken into consideration to work toward an equal access to healthcare. And as the Italian Red Cross and the Red Cross movement, this is something that we have been trying to do through the last years, and we still are in different contexts: national context, international context, and also in emergency one. In the next slide, I will tell you a little bit more about what we are doing and what we have been doing. First of all, what I want to focus is the fact that the community are our main point and my main leverage in keeping up our work. Our volunteers come from communities, are community members, civil society members, and they work actively within their communities. That means that they have something that can help them to get in touch, in the real touch, with people in communities and make the messages pass and make the policies and make the projects get into the communities and empower effectively communities. We do have a strong attention in education, in learning, and this is something that had popped up in many other discussions. And first of all, we historically worked with CPR, and we have in order to be and to create first responders and bystander responders that can effectively act on the field. And this is also have been doing with Philips Foundation. Obviously, we do not stop just on these, because in the last years we have expanded our activities, as you will see in the next slide, and we started focusing in bringing healthcare in rural areas, trying to tackle that accessibility issues that we were talking about before. These proximity medical screening, these proximity medical health posts have been deployed in Italy, and that's become a way to intercept needs and to refer the needs to the national health system. But this is something that we have used also in many different other situations, such as Ukraine, for instance, and in international response and emergency response. Because of course, when emergency strikes, rebuild the primary care services once the emergency has passed is something that is very important. So to us, bringing this with a partnership with Iveco in this case, has been and it will be a promising project to enhance cardiovascular health for people who may not access equally and usually to the healthcare. On the side of these, in the next slide, you will see that we are also working in our local branches to create health centers that are called Officine della Salute, where the people can be visited, people that might not access to the healthcare for many different reasons, migrant people, legal issues, or maybe people that are not actually in the position to be accompanied by anyone to the hospital or to the health facilities, and they can come and find a response and a referral pathway to the national health system. Also, in case of economical issues, they can be provided with medication that can become a huge problem for some part of the population. So coming to the end of this presentation, in our mind, the lesson that we learn, it is, well, first of all, the fact that we need to improve accessibility and access to the services. And we do that, and we must do that by engaging and involving the communities. First of all, our volunteers and the communities they are working within. But we cannot do that alone. We need to do that with the network of partners, private and public partners that we have been working with in the last years and that we want to work with in the future years. This is the only way, a multi-stakeholder, a multifaceted approach that can, in our mind, bring us to enhance the universal health coverage and the accessibility to healthcare. Thank you so much.
Thank you so much. Very inspiring to hear about the power of community empowerment to enable equal access to care, but also to learn more about mobile fixed clinics to truly reach everyone and to enable accessibility, but also to work with wide networks and multi-stakeholders. It's very interesting. So thank you, panelists, for these great insights in the individual countries. And I think we can already see quite some overlap when it comes to disparities and what is actually needed. I would like to move to our final panel of today, where each of you will have a chance to answer questions from the audience. And yeah, I would like to kick off maybe with a question for Professor Pinto. So Professor, given the current health workforce crisis and weakness in the health systems in Europe, How do we ensure no one is left behind when it comes to access to cardiovascular health?
Well, that's a very important and relevant question that we should all very much be considering. And that's why it's so important to have a cardiovascular plan for Europe. Then, of course, can be adapted in each country, although many of the solutions will be across the different countries very similar. I think, first of all, and we have seen from the previous presentations, it's clear that to have a plan will increase the awareness on the issue, the big issue of cardiovascular conditions. And we can consider it from very primordial prevention before having the disease, early diagnosis, so we can start earlier management of the condition, which means access to diagnosis, and then access to proper management. So these are the different steps that we as a society, and particularly now we as a scientific community, have to make sure the decision makers understand, the populations understand how important it is to support this type of actions. And we've seen just a few examples to tackle a condition which, again, I repeat, is 80% preventable. Keep in mind that all the budgets across the world, with some differences, about 94% is for treating. And of course, if somebody has a disease, it needs to be treated. But it's very appalling when we have to treat conditions that we can prevent. It's like taking care or rescuing people after an accident, after a plane crashes or cars crash. We have to work before that. Of course, we have to take care of the diseased people, but before that, there's a lot of work that needs to be done, and that can only be achieved if we really can implement strategies that can help us to prevent cardiovascular disease and to use the resources that we are using now to treat, to prevent, and maybe even use for some other aspects to improve life of the populations. So the big issue here, the way I see it, is the fact that cardiovascular disease, in a way, has been neglected by the decision makers, meaning governments and the people who really can make a difference by implementing, making sure that the strategies are implemented. And that's the role of all of us, because at the end, all of us are potential patients, in potential need of that. And just a final concept, which is the fact that once you have the disease, it's already a bit too late. And that's why it's so important that we work on prevention, we work on early diagnosis, so we can tackle much earlier the condition and improve the outcome of the populations and reduce the burden of cardiovascular disease. We know what to do. We know for a long time what to do. We just need to make sure that we implement that. Keep in mind also, Eurostat has shown that just applying what we know today, 1 out of 3 deaths in Europe could be avoided if we apply what we know today, and about 2/3 of these deaths are due to cardiovascular conditions. So we have a lot of information, we have a lot that can be done, we just have to make sure that this is implemented, because so far we have been failing to implement strategies that can be successful at the more global level, and now talking about Europe, to make sure that we address all these inequities, that we address all these different issues so we can be more successful and reduce the burden of disease, and most of all, to provide cardiovascular health for everybody. It's achievable.
A powerful call to action. Thanks a lot. Great insights. Maybe Dr. Busnatu, we will continue with you. A question for you. So from your experience as a cardiologist in Romania, what in your view is the role of technology in improving access to cardiovascular health in underserved communities?
I would say that with the technology that we have today, we have the possibility to introduce a new medication for our patient. But this is the medication related to prevention. By using technology, by using the gadgets that are available for monitoring the population, integrating algorithms for identifying early signs of disease, not to get to the point that Professor Pinto said, to get the diagnosis of a cardiovascular disease,
Interesting. Thanks a lot. Let's maybe move on to Dr. Narain. A question for you. What lessons can you share about the effectiveness of community screening programs in improving equity in access to cardiovascular health? And what role can primary care play in your view?
Please open your mic.
I think that's a very important question, Victor, and that is where I think the key focus should be in the coming months and years. As I discussed with 16 of the important studies which were done in Europe, and many of them were part of, UK was part of many of those studies, we saw that there is lack of education, lack of upskilling, lack of awareness, lack of research when it comes to primary care physicians. In the UK, we lack almost about 12,000 general practitioners in the primary care. So as of today, we need another 12,000 GPs in the primary care to cater to the demanding population problems. But we don't have those many doctors and healthcare professionals in the primary care, for example. So there's a lot of burden on the primary care physicians to deliver, because cardiovascular disease is not the only thing that primary care physicians are dealing with. They have to deal with multiple problems, from gynecology to skin to pediatrics. So unless somebody like us, researchers, people working in the secondary care, they go and tell us that, look, there is the gap in your area. There are people who are, as per the Office of National Statistics, there are these many people sitting in this postcode, these many people sitting in this postcode who need to be screened for blood pressure, diabetes, cholesterol, and these are all very basic risk factors that we are talking about. We also need to take that knowledge to the wider community as well, for the education of the community as well. So again, the two things has to happen in the UK. One, the upskilling of primary care physicians and specialist nurses and district nurses in the community, because they are the backbone of the system in the primary care. Unless they are updated, they are upskilled, they are trained properly, they won't be able to know, understand where to focus, how to screen those patients that we are talking about, the patients that we are missing, because primary prevention is very important. As Professor Pinto said, that primary prevention is very important. We need to pick up all those high-risk patients, especially because cardio, renal, metabolic, these are the three big conditions which are going to cause a lot of problems for us as clinicians in the coming weeks, months, and years. So I think upskilling of primary care physicians, increase awareness and knowledge and concept in the wider community as well about the risk factors, because at the end of the day, individuals also have to take some responsibility of their health, because we cannot be just dependent on the primary care or the primary care physician, because there's possibly just one GP in my area for 10,000 patients. So again, one GP for 10,000 patients will not be able to cater to all the demand that we have and the rising problem that we have. So I think, so to some degree, personal responsibility of individuals is also important, and that will only happen when we have better education delivery in the wider community about the problems that we need to be focusing on with our advancing age.
Thanks a lot. Very insightful. I also have a question for Dr. Mogini. So involvement from the community has been shown to improve access to cardiac care. and improve chances of survival after an acute cardiac event. From your experience, how can we leverage untrained people in improving cardiovascular health equity? And what lessons can you share about enablers of skill for such programs?
This is a very interesting question. First of all, I want just to cite a little bit of a project that we are doing now, which is related to cardiovascular health in a very wide way, which is mostly based on prevention and schools, where we do provide lessons and learning about CPR, and at the same time about breakfast and the healthy habits. And the students are very happy, the young people are very happy to learn skills that can be applied and that can take with them through their lifetime. On the other end, our experience with community is pretty much wide. We are offering classes and courses in the school, in job places, but sometimes once in a year or twice in a year, we used to have big mass training in the square in Italy, in the central square of Rome or Milan. And I must say that there's a lot of people. It's a massive interest from the communities and from the people in the CPR and in these in learning how to perform this. And fortunately enough, in many different occasions, our volunteers or bystanders that have been trained by the Red Cross had the chance to intervene in some real situation and to change the life and make the difference between life and death for some person. On the last side, something that I want to highlight is also the role of advocacy for the Red Cross, for Italian Red Cross in this case, because we cannot forget the legal framework in which we work. And sometimes, and not in every country, it's easy for bystanders and not for a non-healthcare worker to access to device that can provide electric shock. And this is something that we have been working through the last years, and we got to many results in terms of legal framework and liberalization and of AAD, and so that the population can feel free to use this. Obviously, this is a partnership with the government and partnership with the local authorities.
Thank you. Wow, and thanks for the answer there. And time flies when you're having fun, so I'm conscious of time, but we do still have questions coming in from the audience, and I think we still have time for two. So maybe we move to Professor Pinto with a question from the audience. Could you please provide a concrete example of an action within a national cardiovascular plan? Because I'm interested especially on the preventative area.
Absolutely, and actually there are several examples, but one that I appreciate very much is actually working with children in schools to provide programs for healthy habits, for eating in terms of food, for exercise. And this is crucial because, as I've shown and many of the colleagues have mentioned, education is one of the key factors that actually is responsible for inequity. So to start at a very early stage to educate the future generations on the importance of simple but sometimes difficult to implement measures, such as good plans for providing proper, of course there is a question of access here as well, but to provide proper education on how to eat well, how to exercise, how to prevent obesity and some of the conditions that are related with bad nutrition, with lack of exercise and so on at schools are essential. And let me add also another important element, which is the engagement of patient groups. I think it's crucial today that we in the cardiovascular field do what actually in the cancer field has been done for quite a long time, which is the inclusion of patient groups and patient representatives in the different aspects, even on production of guidelines, on basically doing the interface with the society, because at the end, we are all potential patients, and these patient groups can actually help a lot to provide support in the community and support also at the decision-maker level that can help to implement some of these strategies. Two other important ones that are already in some plans are related to smoking cessation policies, smoking cessation rules, and also in terms of diet, for instance, the reduction of salt in some foods like the bread. In my country, we have this law for quite a while, and it did have already some impact in reducing, for instance, hypertension and so on. So there are many things that can be done, and these are just some examples on where we potentially can achieve more, because this is a long-term run, it's a marathon, it's not something that will be a quick fix.
Thank you very much. So maybe another final question then for Dr. Busnatu. Several times digitalization was mentioned to support access and equity. Do you see centers welcoming these populations in rural areas or low-income regions moving faster to digital tools that can screen or give risk score of developing cardiovascular diseases? And how are guidelines synchronized with digital strategies to address faster these issues for these populations?
Yes, I would say that I would see centers capable of doing these activities, but it's very important when you introduce technology to show to the beneficiaries that they will be served with the technology, not overburdened, because this is the main problem at this moment. And when it comes to implementing the guidelines and the digital health strategies, I would say that in terms of cardiovascular disease, we are at the beginnings. Because, for example, in the secondary prevention and rehabilitation nucleus, we are working now on building some digital standards for ensuring telerehabilitation services for patients. And we hope that these European standards will be taken into consideration in terms of quality for further involvement in digital national health plans.
Thanks a lot. And I wish we had more time. I think we could have easily gone on for another hour, but I think this was already a great conversation and has provided valuable insights into the questions of what we can do to halt the rising burden of cardiovascular disease in Europe. So thank you so much to the panelists and of course the audience for making the time. It was great moderating this webinar and listening to the conversations. So thank you very much, and I wish you a great and of course healthy rest of the day. Goodbye.